am. Okay, thank you. So hello everybody, welcome to Clinical Documentation Integrity Best Practice Part 2. This is going to be more for the C-suite. We're going to go over and some of the numbers that are involved in it. If you joined the last call, some of the slides will look familiar and then some of them will not. This is a 30-minute call, so we are going to get started rather quickly. Okay, so we're going to again talk over the CDI goals. We're going to review the workflow and associated metrics for success in terms of what the leadership need to look at and for this, examine the collaboration, and then again discuss that continuing education. We're going to look at some case studies. We're going to again talk about the staffing models, the medical staff, the workflow, collaboration, and education. So CDI goals, with everything that is happening now, the documentation that is put in the charts when we're caring for a patient is not just the documentation. Most importantly, it is the documentation of the treatment received, but it is also the record of what was done. So when we tell, as providers, when we tell a payer we want to be reimbursed for the treatment of this condition, we need to be able to show that we have provided that treatment to the patient. And sometimes that information can get left out, or in terms of a physician talking to another clinician, being it a mid-level or a nurse or a CNA, they may understand very clearly what is happening. However, the documentation needs to be for everybody to read. So a blood transfusion, we cannot assume that that's anemia. There needs to be some clarification for that. So that is what CDI really works on, or one of the aspects that they're working on. Also, as we move from quantity to quality, and our quality measures are becoming extremely important, and our currently our secondary reimbursement and soon will likely be our primary reimbursement is going to be based off of these measures. We need to ensure that the documentation is clear and concise. I do want to say that this does not mean that your documentation has to be pages and pages long to talk about 20 minutes of time, unless it truly requires that kind. I'm talking about clear, concise, legible documentation that's there. We want to make sure the documentation allows for accurate and specific coding, that it addresses the acuity, the severity of illness, and the risk of mortality of the patient, the clinical truth of what's going on. And in that clinical truth, the medical necessity and the quality of care that the patient is receiving. Length of stay, does the documentation support the length of stay that is there? Clinical denials, this is huge. CDI can help mitigate denials when there is good communication, in that as we know something that may deny, we can work on the documentation concurrently while the patient is being treated and stop the denials before they happen. Timely and accurate reimbursements. If the important thing for us to do as a facility is to make sure we're paid right the first time. CDI can help accomplish that in terms of making sure the documentation is there, the coding comes out correctly, the DRG is correct, and then it all kind of falls into place. And then we want to make sure that we are maintaining compliance with the regulatory and government agencies. Extremely important, overall important that we're following the compliance of that. Again here, the CDI folks are going to be a bridge between the gap between physicians and coders. My background is coding by history, and I know that some coders do not have the clinical knowledge that is necessary to talk to a physician. They may not have access to the physician. They may be remote and not be able to work with them face-to-face. So there are a whole host of reasons why a coder may not be able to get with a physician. It could even be as simple as the time they work. The physicians may come in very early in the morning and the coders are don't come in until the evening. But whatever those reasons are, CDS, nurses and CDS, the folks that are on that role, they can be working with those physicians timely and getting the answers in the chart as is necessary. So case one, we want to take a look at what the how words can make a difference. So the first thing I want you to look at is exacerbation of chronic obstructive pulmonary disease, COPD, with heart failure. This is actually a very common documentation that we see. When I work with physicians, one of the things that I want to say is, you know, if you're working in this chest area, if there's heart failure, we need to know what's going on. So, you know, we want to know what's going on. So when we look at this, if we code it out just as it is, when it says COPD, and it doesn't have a CC or an MCC because we don't have specified heart failure, that goes to MSDRG 192. The weight of that in 2020 is going to be 0.7241. The estimated length of stay is going to be at 2.5. If you notice up there, the patient was here for 4 days. That's almost double. Actually, that is double. That's more than double of that, and the reimbursement is just a little under $4,000. So this is this would be something that we want to address. Nothing is really connecting. Why is the patient here for 4 days? We're treating something that's dealing with the heart and the lungs. Why don't we know what that heart failure is? It's enough for the physician to state they have heart failure. What's going on with the heart failure? Is it affecting the COPD? So if we query the physician, and that physician comes back and says that the patient has chronic but not acute heart failure, and that's what they give us, that becomes a CC. So we're doing a little bit better. And when you look at that, that's a DRG 191. The weight is 0.9139. The estimated length of stay is 3.1, and the reimbursement is just over $5,000. So we've gone up a little over $1,000 now. We've actually gone up on our patient days. We're getting a little closer. Patient had chronic heart failure, so now we understand that, you know, that's what's going on. So we have a better idea of the severity of illness of that patient. But still, we're at 4 days. So what's going on? We're not at that average. So what can we do about that? So if we were to query the physician and they had come back and they had given the specificity of the patient has acute or acute on chronic diastolic failure, that's an MCC. So that MSDRG is 1.9 or 190. The weight is 1.1907. The length of stay, the average length of stay is 3.8 days, and the reimbursement is $6,548. So when we see this and we look at the chart and we look at what's coded, so we have a patient there that's 4 days. Well, the average is 3.8. Okay, so this is making sense. We now know that the patient was there for 4 days because they had acute heart failure. So we were having to treat them a little bit longer. The length of stay makes sense. The documentation, the severity of the illness match the length of stay that the patient was there, as well as we're getting reimbursed for the treatment that we have, you know, that we've already given to the patient. And if you look at that, we're going from just under $4,000 to $6,500. If you do not document to that level of specificity on a regular basis, that's I'm not a mathematician, but that's what, $1,500, a little bit more than $1,500 per case, which can have a huge impact, especially on any conditions that you consistently see. So if your patient population is a population that does have heart failure, then this is definitely something that you want to address to ensure that if the specificity is necessary to identify and document the clinical truth, that it is being done. This is where a CDI team can help. Looking at this again, this shows it in a different way on how words can make a difference. Looking at this information, we're going to assume that the hospital, is $1,000 per day. So when we're seeing this, you can see that if the patient is here for 4 days, the hospital is getting about $900 a day if you're at the DRG, the red down here at 192. Per day, if we're able to get that it's chronic and not acute, the facility is actually getting reimbursed about $1,200 a day, a little bit more than $1,200 a day. And if the specificity, the documentation supports, the clinical presentation supports that the patient has acute or acute on chronic heart failure, we're actually getting reimbursed about $1,600 a day. That makes a big difference. So for the CFOs that are on the call, if you know how much it usually costs to care for a patient per day, you can see how this can be applied to your numbers to see what are going on in terms of, from a financial standpoint, what is going on with our patients and what can we be doing to address this to make sure that if the patient is here for 4 days, they need to be here for 4 days. Or if the patient is here for 2 days, do they need to be here for 2 days? We need to ensure that the reimbursement is appropriate. Okay, so moving on to case number 2, we're going to look at CDI and the coding for pneumonia. So our initial documentation, an 85-year-old female presents from the nursing home to the hospital's ER, has cough, fever, weakness, fatigue, confusion. They have a chest x-ray in the ER that demonstrated a right lower lobe pneumonia. The principal diagnosis is pneumonia. The patient is admitted for inpatient status. The patient is here from 7:15 to 7:19, a 4-day length of stay. So currently, with that information that we have on day 1, we're at a working DRG of 195, which is pneumonia without CC or MCC. The estimated length of stay of that is going to be 2.6 days. And the reimbursement for your general hospital, general hometown hospital, is going to be $4,793. And of note, these are all Medicare numbers. So the CDS person is working with the physician. They do a concurrent query. On day 2 of the admission, the CDI identify a low serum blood sodium level in the lab results, and the physician ordered PO sodium replacement. CES is they queried the physician to determine if the low sodium levels pertain to the kidney failure, hypothyroidism, and adrenal insufficiency, hyponatremia. And the physician came back and said it's hyponatremia. Hyponatremia, when it codes out, is a CC. So in this case, now the working DRG has moved from a 195 to a 194. And this is pneumonia with a CC. The estimated length of stay here is 3.3 days, and Hometown General is going to get reimbursed $5,992. So that is an improvement. So the patient is there for 4 days. The initial review was done. 3 days, the patient's discharged. HIM reviewed the H&P and identified that the patient had a history of valvular heart disease and on current medication included ACE inhibitors and beta blockers. The patient also was admitted for shortness of breath and swelling of extremities. The physician ordered an EKG and continued the patient's home medications. So the coder retrospectively queried the physician to determine if the patient's medications were to treat high blood pressure, previous stroke, or heart failure type, and the physician responded that the patient had acute systolic congestive heart failure. So that is an MCC, and it changed the DRG to MS-DRG 193, which is pneumonia with an MCC. The estimated length of stay of this is 4.2, and the reimbursement for Hometown General is $8,332. Taking a look at this and seeing how the concurrent query and retrospective queries actually can work together, and both can happen. And the reimbursement change with those queries are worth the time that it takes to do that, as well as what we have done as we have indicated the severity of illness and the risk of mortality of this patient. A patient who comes in with pneumonia, and that's all that's going on, is a completely different patient than a patient who has pneumonia, hyponatremia, and acute systolic congestive heart failure. The risk of mortality is going to be completely different on those patients, and we definitely need to make sure that we have documented and we report the clinical truth of the patients that we're treating. So that's giving you an idea of what how it can financially impact you. You know, $2,000 to $4,000 per chart is a huge sum of money if you look at every chart if it's in your patient population. So you definitely want to be taking a look at this at the chart level to ensure that the documentation is there. In doing that, if you're creating a CDI team, and that CDI team can be huge, or it can be a one-person deal, and it can be part FTEs. You know, you may have a nurse and a CDI person coming together, and they're working together to collaborate. But the ideal staffing model for a CDI team is going to be registered nurses, HIM professionals, and physicians. Each of these professionals bring an extremely important point of view to the CDI team that is required to ensure that there's accurate reimbursement, that quality measures are documented correctly, and that compliance is being met. If you leave out any of these professionals in your team, you may be putting some risk there, and you definitely want to make sure that you are taking steps to keep that risk from happening. You lose a point of view, so you definitely want to make sure that that information is there. You may not be able to have a coding person that's both on at the CDI as well, but you want to make sure that your CDI and your coding staff are talking so that we are following all the rules that are required for CDS to be following. Also with that, for my C-suite out there, medical staff, this is extremely important. They need to buy in. We need a physician leader, an advisor, a champion role. We need that person to step in and work with the physicians that don't like to get queries, that don't understand what the process is and why it's happening. And if they disagree with something that's going on, the staff, the medical staff as well as the CDI staff need somebody who can help collaborate between the two of them so that that information can be successful. Also, the peer-to-peer interactions. If a person is willing to learn, they can be trained, but sometimes there are cases where it needs to be physician to physician, nurses to nurses, coding to coding. And so we need that physician advisor champion to take on that role to be that person. And again, they may not agree. So you need an escalation policy. We need to know what's going to happen with that because somebody needs to make a final decision so that the chart can be closed and we can move on. So you definitely want to have those in place in terms of having it together. Talking about workflow, this starts from the very beginning and it can happen over and over again. You want to identify your at-risk areas. Is it going to be a diagnosis? You know, sepsis, pneumonia, altered mental status. These are all huge issues that we're all facing in today's healthcare. It could be specialty. Ortho is a big one. Neuro, anything that's going to be surgical is going to fall under that. Quality, what are your PSIs looking like, your readmissions, your admission, your present on admission diagnoses? Do you have hospital-acquired conditions that need to be addressed? CDI is great at helping with this. And again, your covered days. Does it make sense? Are your patients in the hospital as long as they need to be and truly not a minute longer? We want to be working with case management, and you are in terms of getting that documentation to support that length of stay. In terms of workflow process, when you're working with your CDI folks, how are they going to tackle the patient population that you have, those that are in the house? Are you going to do it by payer? Are you going to do Medicare, Blue Cross Blue Shield, and Cigna? Or do you want to do it by department, ortho and neuro? Are you going to split it specialty? Are you going to split it by specialty or by floor? Is one CDI person going to take floor 1 and then the other person take floor 2? For KPIs, the C-suite, they really need to understand all of these CDIs or these KPIs. The one thing, or there's a couple things that I want to point out for you all. Denials are huge. If you have a lot of denials, the folks that are working your denials need to be working with your CDS so that your CDS can mitigate and stop those denials before they happen. Take that process and find out what's going on. Your review rate, you know, how efficient are your CDS in terms of getting the charts reviewed? Your query response rate and time are extremely important. You definitely want to take a look at those. And the agreement rate. You have a physician who's just not going to answer a query. That person needs to have a conversation and so that they can get on board and understand. CDS are here to help the practitioners. CDS and coders are in the chart much longer than the physicians are and the practitioners are, and they can take that extra time that they spend in the chart can be hugely beneficial to those practitioners in terms of getting documented what needs to be documented. You know, they are there to help the physicians and practitioners, and we need that to happen. CDS is all about collaboration, and as a C-suite, this is something that definitely needs to be supported. CDI, where they're working with the documentation that is present in the chart, it touches everything that happens in the facility. So compliance needs to be involved. Quality needs to be involved. We've already talked about case management, your medical staff, HIM, your denials. The Rev Cycle folks, they need to know what's happening in CDI and things that are changing, especially if something's getting ready to change. Let your Rev Cycle folks know so that they can expect it to be a little bit different. And then your internal auditors, if you find something that's at risk, get your internal auditors to help you with that and monitoring and seeing if that's improving or not. It's extremely helpful and very important for collaboration to be happening. Physician education, we want to make sure that that's happening. You need to set it up. Your physicians need to be involved in this. Documentation, practices. If Dr. Smith does not like to be specific in his documentation, he probably needs some one-on-one training. If it's something that's happening across the board, you probably need to do facility-wide training. Trends and benchmarks, physicians need feedback. They want to know how they're doing and how they can improve. Orientation, when you have new folks coming in, get your CDI folks in there with them fast, let them get a relationship with them, and so that those new practitioners understand who can help them in terms of getting their documentation right then, right there. What is the best medium for education? Is it going to be a short face-to-face? Dr. Smith may only want to talk very little. Dr. Jones may want a whole hour, and he has lots of questions, or she has lots of questions. Is it going to be medical staff meetings? Do you need your CDS or your coders to come in at those staff meetings and come in and talk about something? Or is it a newsletter where your physicians actually read the newsletter? Is that better than trying to set up the time to do face-to-face? Competition, again, if you can make this fun and enjoy it, physicians love competition. I've had several physicians say this to me. They want to be the best, and they like knowing they're the best. And if they're not the best, they will work to be the best. So being able to come up with something that is fun, collaborative, and has a bit of competition into it, physicians tend to enjoy that. So that's something that makes it just a little easier for them. They're going to need to do it. We might as well do it with a smile on our face. And the last thing that is extremely important here is going to be the physician the education between the coding and the CDI. This meeting is often drops off. They decide it's not necessary. This is so extremely necessary. Make sure this stays on task. They need to meet. They need to collaborate. They need to be working together. It can be difficult to understand from a CDS perspective and a coding perspective, and they need to be able to communicate and collaborate with each other in order to get over that hump of communication. Especially if your CDS is coming from a nursing background and then your coder has a coding background. They're coming from two different points of view. They need to work together so that they can work together. So you want to make sure they're meeting, they're coming together, they're talking about these things. Documentation practices. You know, Kelly, the CDS, has been working really hard with Dr. Smith on stating stuff that's vague, and she's gotten CHF. He's being really accurate about that. And when she meets with the coder, she finds out, well, that's great, but, you know, he won't tell me what kind of diabetes the patient has. Oh, well, there we go. We got to work on that, too, so it's not just CHF. So having those conversations and knowing where the CDS can go back and work with the physician. Benchmarks and trends, what are those for your facility? What are those nationwide? Your case mix index, where is that fluctuating? Are there things there that need to be addressed? Coding practices, this is a great place for to help CDS understand why the DRG is something that makes no sense in terms of what the principal diagnosis is, and the coder can start educating them on what these rules are and what they need to be. New techniques, new technologies, new services, new federal regs, again, denials, and then audit findings. These all need to be discussed between the teams on a regular basis so that we can all stay on the same page. The time is just about up, but I did want to see, does anybody have any questions? I've not seen anything come up on the chat box, but if anybody has any questions, please let me know.
All right, well, again, if anybody has any questions, please don't hesitate to reach out to us after the call. We're happy to connect you with Heather or anyone else from BKD. Heather, thank you so much for your time this afternoon. And I just want to give a quick reminder about the next Revenue Cycle Improvement webinar with BKD. It will be tomorrow morning from 9 to 10 a.m. Central Time. And that one is focused on telehealth, getting started with proper coding and billing of telehealth services. And I know that DRC-HSD participating organizations are at very different points as far as involvement in telehealth, but we do still encourage everyone to attend. For those of you that have already had the telehealth assessment, hopefully some of the information you'll gather will help you move forward implementing some of those recommendations. And for our cohort 2019 organizations, we hope that that helps kind of